This is my acute care 2 case presentation. History of present illness. Patient is a hypertensive and anxious 64-year-old male at baseline who presented to the facility with profound altered mentation requiring 4-point restraints following 24 hours of increased agitation at home observed by family. Per discussion with family and note review, as patient is alert, however completely disoriented. Patient began to exhibit increasing agitation in the early part of the afternoon, 24 hours prior, escalating into periods of hyperactive, self-destructive escapades that would find him naked, defecating in the open corridors of his home and terrifying his dogs. Previous medical history: congestive heart failure with AICD in situ, chronic pain, and ventricular tachycardia. Wife reports a history of admissions for similar psychiatric destabilization in 2012, 2021, and 2022. To this end, patient wife states that her husband has not been exhibiting any signs of distinct mania, hallucinations, paranoia, suicidal ideation leading up to episodes today, and further indicates that he has not been taking any illicit narcotics or been in contact with illicit cohorts. Patient did recently have his daughter pass away towards the end of September and has been struggling with that. Review of symptoms. Patient is unable to partake in the exam. Physical exam. The patient is delirious and will track rhythm, no focal neurologic deficits. The patient is hypertensive and has episodes of tachycardia on the monitor. He's in 4-point restraints with the Glasgow Coma scale of 10. Pupils are intact, +2, with normal conjunctiva. The patient's general appearance is frail, hyperkinetic. He's thrashing around in bed in the 4-point restraints. Eyes closed, teeth clenched, will open his eyes to voice, maintains brief eye contact, and persists with scattered hyperkinetic episodes. His behavior is hostile, non-purposeful, non-directable, and extremely agitated. He is speaking in English with no slurring, mostly clear, repetitive, pressured, and loud mood and affect. Psychiatric, he does appear agitated, does not appear to respond to any internal stimulus, aimless and hyperverbal, mostly religious themed 3 to 5 word phrases, me, Allah, 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 okay, no, 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 anxious and aggressive. The patient's thought process is disorganized, tangential, and self-persecutory. Aspects of self-persecutory is it's on me, it's my fault, no, no, no. The patient is disoriented, he's confused, he has poor memory, poor judgment, poor insight, and absent intelligence. All other body systems on the physical examination were within normal limits. Diagnostic tests. The patient had a normal CBC with minimal electrolyte destabilizations. The serum CO2 was 20, BUN 25, T-Billy 1.4, and lactic 2.3. Additionally, the patient's urine drug screen is positive for benzodiazepines, cannabinoids, and oxy, with home mec rec demonstrating a prescription for clonazepam and oxycodone 10 milligrams to explain. Patient with an unremarkable CT head with evidence of atrophy and small vessel ischemic changes throughout, with acute sinus, along with an unremarkable CT of the abdomen and pelvis. Social history. The patient is an active 2 to 3 pack per day smoker with greater than 150 pack per year. No alcohol or illicit drug use. The patient worked as an industrial electrician for 40 years, became disabled, and is currently on disability and Social Security. His mother is deceased. His father is deceased. He has one brother who is deceased. and he's a full code. Differential diagnoses include metabolic encephalopathy, a CVA, and drug overdose. The actual diagnosis is delirium that is drug-induced. The patient is positive for cannabinoids outside medications prescribed at home to treat his underlying anxiety and chronic pain. Per report, patient does not sleep well at baseline, has been sleeping even worse over the last several weeks, which could obviously contribute to exciting his current state. Functionally normal as of noon on 11/5 of 2023. According to the patient's wife, similar admission back in 2012 with records showing a hospitalization surrounding alcohol detox with efforts with planned ICU course for the DTs. Patient's CTOH level was negative today. However, given his history of alcohol abuse, a banana bag ×1 was given. The plan will be ICU observation with Precedex to treat the acute hyperactive aggression state. Restraint ×4 placed in the ED, reasonable to continue given the patient's demeanor, and danger to himself and staff until his mentation can clear. Diagnoses continued. Aggressive behavior. The plan for acute antipsychotic and anxious control will be Haldol 5 milligrams every 6 hours as needed. Polysubstance abuse. Patient is prescribed both benzodiazepines and oxycodone at home. Other than testing positive for THC, unsure of actual abuse mechanism. As mentation clears, we can further explore intent/amount of self-medication. Anxiety. The patient has baseline anxiety, seemingly poorly controlled on home medications. Potential benefit for additional antipsychotic medication is Zyprexa. He has other social stressors in his life. He's had a recent loss of his daughter. For a history of alcohol abuse, we'll treat with the banana bag. No reports of alcohol consumption at home. Should he become tremulous, we will start the CWA coverage and treat the DTs.